Hi, good evening.
Good evening, ma'am.
Good evening, ma'am.
Yeah, good evening. I think there are not much takers for today. We'll start the session anyway. Okay. So, Deepak, say you were willing, right, for
Yes, ma'am. I haven't read the whole of the comic, but just I'll want to give it a try.
oh yeah, okay, no problem. So you able to see my screen?
Yes, ma'am.
So so the session will start something like this. So they'll give you a question. We'll give you they'll give you 5 minutes for you to write down whatever you want to say regarding this particular question. So this is your primary question. The time is 8:02. We'll wait till 8:06 or 8:07 or so that you can recollect what all you want to say for this question.
Sure.
Okay.
Yes.
You can even write it down what all you want to say, because you just want to.
Will I start, ma'am?
Yeah, you can start.
So the factors, first of all, the foremost factor which determines the. Can you put the question on display? Hello.
Sure. I'm just sharing my screen.
So the first and foremost factor which determines the uptake and distribution is the route of administration. Like the
Okay.
Intravenous route is the route which has the maximum bioavailability. So the drug is distributed and the uptake is very fast and drug is distributed very fast. Then after route of administration, the factors which determines this is the lipid solubility, then the ionization, the tissue blood flow, then the pharmaceutical preparation of the drug, then the first pass metabolism of the drug. So these are the factors which determine the uptake and distribution of the drug.
Do you have anything to say about the protein binding of a drug? What do you know about protein binding, and what are all the protein to which the drug binds?
Yes, protein binding also affects the uptake and distribution. Protein binding denotes the drugs which are bound to the proteins, mainly the albumin and the alpha-1 acid glycoprotein. The albumin is more in, like, the affinity for albumin is more as compared to the alpha-1 acid glycoprotein. So the drugs which are more protein bound has got extensive distribution.
Okay. Can you come again about the protein binding?
Well, protein binding is the drugs bound to the proteins, mainly albumin and the alpha-1 acid glycoprotein.
Okay.
The albumin has got higher affinity for the drug. The albumin has got the higher affinity for the basic drug, and the alpha-1 acid glycoprotein has got the higher affinity for the acidic drug.
No, it's the other way.
Alpha-1, yeah, sorry. Alpha-1 acid
yeah.
glycoprotein has got for basic drug, and the albumin has for the acidic drug.
Okay. Okay.
The more protein-bound drugs are more extensively distributed, and they have got a longer duration of action.
Okay. Okay. So, can you tell something about the placental transfer of drugs, of the routinely used drugs? Or what are the factors which affect the placental transfer of drug?
Placental transfer basically depends on the lipid solubility of the drug, most importantly.
Okay.
The more lipid soluble drugs are more able to cross the placental barrier.
Okay.
Then the degree of ionization, more ionized drugs will cross less. Then the blood flow to the placenta, more the blood flow, more the placental uptake.
Okay.
Then the molecular size also affects the
Yes.
bigger the size of the drug, like the more heavier the drug is less likely to pass the placental barrier.
Okay.
Like opioids crosses readily, and in opioids specifically, as the fentanyl is more lipid soluble than morphine, so fentanyl is more likely to cross the placental barrier as compared to morphine.
Okay. Can you tell something about transdermal preparations?
Pardon me?
Transdermal preparation of any drug.
Transdermal preparation. So transdermal preparation is another route for drug administration, where the drug is distributed on a patch, which is the patch is stick to the skin, and through the ionophore mechanism, this drug is gradually released from the patch, and it is taken through the skin mucosa. So it has got stable, the drug level reaches a steady state, and it maintains a steady state level. And but the problem is depends on the blood supply of the area. If there is vasoconstriction, like in the cold, due to vasoconstriction, the blood supply will be less, the absorption of the drug will be less. So it depends on the local vasoconstriction or the vasodilatation state. Then the
so we can tell about what are all the advantages. So it avoids the first pass metabolism, and
it avoids the first pass metabolism.
Yeah, and you can also add about what are the common drugs which are routinely used as transdermal preparations.
So the drugs which are commonly used as transdermal preparation is the fentanyl patch, the diclofenac patch, the oxytocin patch, then the hyoscine patch, and
the most common one which is used is like for cardiac, so glyceryl trinitrate.
Glyceryl trinitrate.
Okay. Okay. Can you tell something about adrenaline?
Adrenaline is adrenal medullary drug, medullary hormone. It is an adrenaline is basically is released from the adrenal medulla. It is it acts through the GQ type of receptor, G protein coupled receptors of GQ type, and it has got action on all the receptor subtypes alpha 1, alpha 2, and the beta 1. So it increases the contractility as well as it reduces it causes vasoconstriction also. And it is metabolized into like through the myo or the form pathway.
You can just come like whatever you use, like you can just tell when whatever the drug they ask, no, please have a format to tell so that you won't forget which way you're telling. So you basically tell which drug it is. So adrenaline, it is a sympathomimetic agent. So you say what are the formulation it comes in. It comes is an intravenous preparation at the dose of 1 milligram per ml. And you say like what are the pharmacokinetic effects and pharmacodynamic effects. You can say, you always, whenever they ask about a particular drug, whatever comes into your mind is say about CVS effects, say about CNS effects, RS effects, and any specific effects you know of. And so in case of adrenaline, the CVS effects, no, you should have to tell about it's a cardio inotrope plus a sympathomimetic agent, increases the heart rate, increases the blood pressure, and acting on the beta 2, it can also cause vasodilatation. And you can say in respiration, it brings about bronchodilation, being a sympathomimetic. And in gut, you can say like it decreases the peristalsis, and so on. Like that, you have to keep on adding points. And like you say about uses are like it produces given in the ACLS guidelines as CPR, and you can say it is used in anaphylaxis at a dose of 50 to 100 mics. It is used for refractory bronchospasm intraoperatively as a nebulization, and you can say it is like used to find out the vascular absorption of a locally injected agent in an epidural at a dose of, and it is used as a vasoconstrictor in the peripheral nerve blockade to increase the duration of action at a dose of 5 mics per ml. So for adrenaline, we should not think much. Okay. Hello?
Yes, ma'am. Yes, ma'am.
Yes. Okay. Shall we go to the next drug so that you can be comfortable? You just make yourself clear that you will say in all these headings, so that even if you don't say it in all these headings, no, it's not a problem. But then your mind will start thinking to what you must say in the exam. Like, okay, now this drug, it's okay. Shall we try the same thing for, and you say about whenever you, for adrenaline, we don't talk about protein binding. You say about duration of action. You say about what are its pharmacokinetics, like how it's metabolized and all that. So shall we say that, try the same thing for morphine?
Yes, ma'am.
Yeah, morphine.
So the morphine is a naturally occurring opioid. It is available as an oral preparation. It is available as IV formulation. The same preservative-free preparation can be used for the intrathecal and the epidural use also. For the IV, it is available as 10 milligrams per ml or the 15 milligrams per ml. In oral preparation, it is available as 2 milligrams tablet, 5 milligram tablet, 10 milligram tablet, 30 milligram tablet. It mainly acts on the mu opioid receptor, the strong mu opioid receptor agonist. Regarding its pharmacokinetics, it is like oral bioavailability is only 10 to 30%. Then the volume of distribution is around 4 liters per kg. And it is not as lipid soluble as fentanyl, and its clearance is around 16 ml per kg per minute. Then regarding the metabolism, it is metabolized mainly in the liver through the glucouronidation. Majorly, the product is morphine-3 glucouronate, which is around 70%, which is inactive, and the 20%, 20-25% is morphine-6 glucouronate, which is the active metabolite more active than the morphine, and ultimately it is excreted to the kidney. So we have to avoid its use in the case in the patients of renal and the liver failure. Regarding its uses, uh, it can be used as a analgesic action in the intraoperative. It can be used as a for the analgesia in the palliative care, and it can be used in the intrathecally or the epidurally for prolonging the action of the local anesthetic drug. Then regarding the pharmacodynamics, in the CVS, it uh, it has got like two receptors, the types. It acts on the mu and the mu one and mu2, and in CNS it causes sedation, it causes euphoria, it causes meiosis through the Edinger-Westphal nucleus. Then it causes respiratory depression through the central pathway. Uh, in respiratory depression, respiratory rate is reduced more than the tidal volume. Uh, then in the cardiovascular system, it causes bradycardia and through peripheral vasodilatation, along with the bradycardia, it causes um, uh, a little bit of hypotension due to histamine release. In respiratory system, it reduces it causes respiratory depression, and the respiratory rate is reduced more than the tidal volume. The response to the hypercarbia is reduced more as compared to the response to the hypoxia. Due to histamine release, it causes bronchospasm. In GIT, it causes constipation, and the causes the it causes
contraction.
Contraction of the sphincter of Oddi, and it causes urinary retention. Then and the chest wall, it causes chest wall rigidity.
You did not think you can just go for complications, and they won't expect you to say each and every point. You can go to uses, complications, side effects, and say like, I'm done. That's all.
So the complications associated are we should avoid it in the pregnant females because it can cross the blood placental barrier. It can cause the fetal respiratory depression. We have to monitor the patient after giving morphine because of the risk of the respiratory depression. Then we have to cautious while giving morphine in the patients of renal and hepatic failure. Then we have to avoid the morphine in the asthmatic patients because of risk of bronchospasm.
Okay. Can you tell something about dexmedetomidine?
Dexmedetomidine is it is a centrally acting alpha-2 agonist which acts on the presynaptic receptors. It is a synthetic drug. It is available in the vial of 50 microgram per ml or the 100 microgram per ml. It is used in the doses of it is used for the IV sedation in the ICU. It also blunts the stress response of laryngoscopy and the airway manipulation. It is used in the doses of it is given as a bolus dose of first of all as a bolus dose of 0.5 to 1 microgram per kg per minute over 10 minutes. Then we have to reduce the dose. We have to reduce the dose to 0.2 to 0.5 microgram per kg per minute over 0.2 to 0.5 microgram per kg per minute. Regarding its pharmacokinetics, sorry, ma'am, I didn't read about the pharmacokinetics.
It's okay.
But
you need not wait. You need not say you haven't read. You can just go on, tell whatever you know. That's all.
Okay. So regarding the pharmacodynamics, on the CNS, it causes sedation. It causes sedation. On the CVS, it causes bradycardia, hypotension, and in the respiratory system, it preserves the reflexes, laryngeal reflexes. So it can be used in for the procedural sedation, where we need to avoid the intubation. Then just that much I know.
Okay, lignocaine.
Yes, lignocaine is a local anesthetic drug of amide group. It is uh, it is available in a solution of 20 milligrams per ml. It is formulated uh, without adrenaline and with adrenaline. It is available in the percentage of 2%, 4%, 10%, and 0.5%. 0.5% is used for intrathecally administration. Then 2% is used for the local application, the nerve block or the local anesthetic in the peripheral block. Then 4% is used for the topical application, and 10% is used for the mucosal spray. Then it acts on the basically sodium channel through the inward sodium channel after crossing the lipid bilayer. Then regarding the pharmacokinetics, it is like highly protein bound. It is protein bound is around 70% protein bound, and it has got a pK of 7.9. So it is around 25% like unionized on the physiological pH. So that's why the more of the drug is available. So it is a faster acting drug. Then it has got a terminal its terminal half-life is around
So the speed of onset of action is related to its PK.
PK.
Yeah, PK. PK is close to pH, so the speed of onset is faster because
yeah,
the
7.9.
Yeah.
7.9.
So what's the PK of bupivacaine?
PK of bupivacaine is 8.4. So more
8.
like 15% of the drug is only
8.1. 8.1.
8.1. Okay.
Yeah.
So only 15% of the drug is in unionized form. So it has got lower acting than as compared to lignocaine.
Okay. Can you tell something about ondansetron?
Ondansetron is an 5-HT3 receptor antagonist. It is available as 4 milligrams per ml. Sorry, 2 milligrams per ml solution for IV use, and it's mainly used for the nausea and vomiting, for prophylactic nausea and vomiting, and for the treatment of nausea and vomiting. In CVS, it can cause QT prolongation. So we have to watch while giving the drug. We have to give it really slow. And
so those oral preparation also is available, right? For ondansetron.
Yeah, oral preparation is also available in a dose of 4 milligram tablet.
Okay. Like Amiflim also is available. Like a film like Amiflim also is available, no?
Like transdermal preparation?
Amiflim, like you can keep it in the tongue and then it will get absorbed. So you can say like ondansetron, all of us will be knowing only that much. So it doesn't make much of a difference also. And can you tell something about an EMLA cream?
Yeah, EMLA is basically a eutectic mixture of local anesthetic. It contains 2.5% silocaine and 2.5% lignocaine. Eutectic mixture means the freezing point is depressed to the level of the both of the drugs, and it retains the property of both the drugs, lignocaine and the silocaine. And it is used. It is a type of local anesthetic, and it is used to anesthetize the skin, basically in pediatric patients. While before putting the IV cannula, it is applied on the skin, and adhesive dressing is applied over it for 60 minutes before cannula application. Its like main side effect is it can cause methemoglobinemia because of cytokine, which gets metabolized to orthotolidine. It can cause methemoglobinemia. So the drugs which can cause methemoglobinemia should be avoided with this amlachrine. And the treatment of methemoglobinemia is methylene blue 1 milligrams per kg.
Okay. Atracurium?
Atracurium is a synthetic benzyl isoquinolinium ester group, non-depolarizing type of muscle relaxant. It is available as a solution of 10 milligrams per ml solution in 5 ml, 2.5 ml vial and 5 ml vial. Then it's given in a dose of 0.5 milligram per kg for the intubation, for intubation, and for the maintenance it is used as 0.1 milligram per kg. Then it acts on the basically it is because of non-depolarizing muscle relaxant. It acts on the post-synaptic receptor, acetylcholine receptor, as a non-competitive inhibition. It blocks the 1-alpha group of the acetylcholine receptor and prevents the acetylcholine to exert its effect. Then it is used basically to for the induction while intubating the patient in ICU or the during surgery, elective cases. And then regarding its pharmacokinetics, it is metabolized through Hoffman elimination and through the ester hydrolysis. Through ester hydrolysis, it is metabolized to adenosine, which is not active, but it can cause seizures, which has been shown in animals only. So it is safe to give in patients of renal and the liver failure because Hoffman elimination is a spontaneous degradation on a room temperature. Then regarding the serious effect, it can cause hypotension because of histamine release, and because of that histamine release, it can cause bronchospasm. So it should be avoided in the asthmatic patient. And in pharmacokinetics, it has got 10 isomers.
Okay. Something about diclofenac sodium?
Diclofenac sodium, it is the non-steroidal anti-inflammatory drug group of drugs. It inhibits the cyclooxygenase enzyme, the COX-1 type of enzyme, and so the pathway is the pathway is directed towards the prostaglandin, and through that it causes the pain relief. It is available in the solution as a 1 ml or the 3 ml vial. It is 75 milligram vial. In 3 ml it is 25 milligram per ml, and in 1 ml it is 75 milligram per ml. And it can be used intravascular or the intramuscular. In the dose for the IV preparation, IV route is 1.5 milligrams per kg, 1.5 milligrams per kg, and then it is used mainly for the intraoperative and postoperative pain relief. It is metabolized through the kidney, and so it should be avoided in the renal failure patient. And on the because because it uh, causes the prostaglandins to increase to more.
No, the thing is like
Leukotrienes, sorry. It causes leukotrienes to increase more. Uh, it causes bronchospasm, so it should be avoided in the asthmatic patient.
And diclofenac is not a selective COX-1 inhibitor. It's both a COX-1 and COX-2 inhibitor. COX-1 is an innate enzyme, so it is present in gastric mucosas and kidneys. So they are both protective. So once when they are abolition, you have to say about gastric irritation, peptic ulceration, dyspepsia, and all that for the adverse effects, and they are their GIT effects. And you told about the RS effects, and you have to take. Say about it is usually associated with it has been told to be associated with increased risk of platelet aggregation and bleeding following any ortho surgeries, and actually it is metabolized through liver only, but it is excreted through kidneys because they are actually having inhibitory effect on COX-1 also, which is renoprotective. They are basically avoided in any acute renal failure patients. That is it. Okay, then can you tell something about sevoflurane?
Yes, sevoflurane is the inhaled anesthetic. It has got in structure. It has got seven fluoride carbon, 7 fluoride atoms, and
no, you not think at all. It's an inhalation agent. You say it's a fluorinated inhalation agent. Then jump on to whatever you know. It is given through inhalation route. The MAC value is 2, and
so it is given through inhalation route, and its MAC value is 2. Its blood gas partition coefficient is 1.78. It's 1.78. So it's faster acting and faster offset than the older inhalation anesthetic. It can be used for the inhalation induction in the pediatric patient as well as adult patients because of its present odor. And regarding its pharmacokinetics, it is metabolized to compound A, which is seen to be renotoxic, and it also and regarding the pharmacodynamics in the CNS, it increases the cerebral blood flow. It increases the cerebral metabolic rate of oxygen production, oxygen consumption. It increases the cerebral perfusion pressure. Then in the CVS, it causes hypotension. It causes bradycardia, and in respiratory, it is non-irritant to respiration. It causes bronchodilation, and
okay, something about remifentanil.
Remifentanil is a synthetic amylinopiperidine derivative. It mainly acts on the mu opioid receptors. It is available. Its dose is it is given as a bolus of 1 mic per kg, and then infusion of 0.0125 to 1 mic per kg per minute.
Okay.
And it is used for ICU sedation. Then it is used for suppressing the blunting the stress response or the hemodynamic response to laryngoscopy and the airway manipulation. Regarding its pharmacokinetics, it is remifentanil is non-accumulating because context-sensitive half-time is it's 0. As soon as we stop the infusion, patient is awake in no time. So it can be used for a longer duration of sedation. Then
It's 4 minutes,
It's
no? The contact sensitivity half-life.
Yeah, 4 minutes. Yeah.
Okay. Okay.
Then it is metabolized through the liver hepatic route through glucuronidation and the N-demethylation, and then
No,
it is
no. Remifentanil is like it is.
sorry. It is through that
Yeah.
non-specific tissue esterases.
Yeah.
Non-specific tissue esterases. That's why it's not non-accumulating, and its preparation has got one preservative, so that's why we cannot use it intrathecally.
It's got glycine as a preservative, so hence it cannot be used
Yeah.
intrathecally or
So
epidurally.
we cannot use it in the intrathecal route.
Okay.
Then the effects are majorly like that of morphine only, as you said.
Okay. And does it have anything to do with plasma cholinesterase deficiency?
No, ma'am.
No. Usually,
it is not metabolized through the. It is not
yeah,
metabolized through the butyryl cholinesterase, the plasma cholinesterase enzyme.
So it is not affected in plasma cholinesterase deficiency.
Yes.
Okay. I think you have answered somewhere around 30 minutes of pharmacology. So what usually happens is, apart from this, you will be telling about atropine, no? They'll stop you in between and then ask about atropine or any other drug which they want to. It doesn't mean you have not answered well. It doesn't mean you have answered well. They tell it at the start only. I waited for you to answer the whole thing, right? They don't wait as such. They say about adrenaline. You will be saying something about adrenaline. If like all of a sudden they'll say something about Dexmed. They'll keep asking you questions so that your 25 minutes doesn't feel like 20 minutes also. You'll be asked about more drugs like that. So your first question, which I said no, that will be asked somewhere around for 5 minutes or so. They'll wander around that question for 5 or 10 minutes. And then the remaining 15 minutes will be like, say this drug, this drug, this drug, this drug.
Okay. But yeah, with this viva, I got in a habit of answering in a format. Because
for all the drugs, no. Initially, you say if it's a you told for this remifentanil, no, it is a synthetic anilopiperidine derivative. Like that, for if you take what to say atropine, so it is like you will say it's a non-depolarizing muscle relaxant belonging to benzyl isoquinoline derivative, and so it is an intermediately acting muscle relaxant. That's all. Then the next thing which will come is it is how is it presented? It is presented as a vial which contains either 2.5 ml or 5 ml. Then you say what is the dose? You say 0.5 milligram for induction. For maintenance, it is 0.1. Then you jump on to the pharmacokinetics. Say how much it is protein bound or what is the volume of for every drug, we cannot remember extensive volume of distribution. You just say in kinetics, you just say it is metabolized by this and it is eliminated by this. And it is for bupivacaine, for like for opioids, all those we can remember. And for induction agents, we can remember which are all highly protein bound. And diclofenac is one which is highly protein bound. So you can remember only very specific drugs which are highly protein bound. So for local
that's what I want to ask. Like, if we have to remember, if we need not remember all the
no. Actually,
protein binding, the clearance, and the distribution.
Yeah, it is humanly impossible to remember all these. When you said the clearance for morphine and volume of distribution for morphine, no, I was astonished. For me, I didn't say
because I read it today only.
No. I can understand, but then like it is really not possible to remember all those values. I'll just say when it has got a protein, it has got a moderate amount of protein binding. That's all. I cannot really remember all those. You can remember it today, but I don't think you will be able to reproduce the same in the examination. So you say it is like highly protein bound drugs, or like I make a notes of what are the drugs you feel like are highly protein bound, like bupivacaine 95% protein bound, and medas. Yeah, and for each drug, no, we'll have one particular point which is very important to tell. For atracurium, say Hoffman elimination and ester hydrolysis. For remifentanil, you should not miss this point of it is contact sensitive, half-life is less. And one more clinical point which you can add about remifentanil is you have to add on an analgesic agent because it's not going to act for long. So post-operative analgesia, you have to add some other thing. And another thing you can add for it, it's a very hemodynamically stable agent and it does not cause any much of hemodynamic perturbations. And for respiratory also, like it is the same. Like for any other opioids, it's the same. And for atracurium, you will say this. For diclofenac, you will say like you should not forget about gastric irritation, bronchospasm, like that. So you can say about pharmacokinetics, dynamics. You always think about CVS, CNS, RS, and for specific drugs only, we'll be saying about gut and all. So for CVS, no, whenever you say, you think about heart rate, blood pressure, SVR, contractility. Okay. So if you think about sevoflurane, you will say about heart rate is not affected much. SVR is decreased. Contractility is decreased. That's all. For CNS, you will always think about for any drug you take, whether it is epileptogenic, whether it will affect the ICP, whether it has got anything to do with carbon dioxide reactivity, whether it will increase the cerebral blood pressure, cerebral vasodilatation or vasoconstriction. So you are not going to get anything more than this. If you take this for morphine, no, it does not have any effect on cerebral blood flow. It does not it is not an epileptogenic. It decreases the carbon dioxide responsibility and it has no effect on ICP. Like that, you have specific points which you must tell. So that if you take sevoflurane, it has got a cerebral vasodilatation property. It does not ICP effect is not increased much, and it has got cerebral CO2 reactivity is decreased, and that it is not epileptogenic. Like that, you can finish it off. So you have for whatever drugs I told, no. Wait, I'll say the same thing for Dexmed also. So in CNS effect, one thing which you must not forget is the conscious sedation for Dexmed. So it has not cerebral blood flow. There is no much effect. If it decreases the mean arterial blood pressure so much, then it can have an effect on cerebral blood flow. So it is not epileptogenic. It has got no very minimal effect on ICP. Then it is not epileptogenic. That we finished. So carbon dioxide responsibility reactivity is not much affected with dexmedetomidine. For CVS, you can say it decreases the heart rate. It has got very minimal effect on SVR. It does not decrease the contractility. It decreases the blood pressure. For respiratory system, you can say whether again for respiratory system you say whether the rate is reduced, tidal volume is reduced, response to bronchospasm or bronchodilation. If you have this format in hand, no, for any drug you can say, even for ondansetron you can say it has got no effect on the respiratory system, whereas in whereas in the CVS system it can precipitate any drug comorbid administered with the QTC prolongation can cause an R-on-T phenomenon and precipitated dorsal pointus. Okay, for lignocaine also it's the same. Whenever you say whenever you say toxicity for sevoflurane, you will tell about the renal toxicity which you know of, and it is like is still discussed, but then it's not proven in human studies. You will see for toxicity for lignocaine, you will say CVS toxicity and CNS toxicity, but CNS toxicity is more. The CVS to CNS ratio is actually 7:1, and it is more CNS toxic. The toxic dose is 1 to 5 mics is the normal dose. So 5 to 10 mics, 10 to 15 mics, more than 25 mics. Like that, you can keep on adding. In CVS, again, you can say, no, it is an anti-arrhythmic agent. It is given for ventricular arrhythmias. It has got no effects on the atrial arrhythmias, and it has like a cardiac stable property. It does not decrease the SVR much, and contractility is not affected much. So for all, and lignocaine, it is actually given for bronchospasm as an infusion also. So it is a bronchodilatory agent, and it has got it does not affect the respiration per se. It does not affect much. So if you for it, you can say the CNS effect also. If you have one format for CVS, RS, and CNS, and for gut, we'll tell only for specific drugs. No, it's an anti-emetic means you will tell it is like prokinetic means you tell it increases the peristalsis in the forward direction and so on. So, but for every other drug, we will not be able to tell about the gut function. So adrenaline you can say, atropine you can say, but you I don't think. I mean, I did not get anything for the GI effects. So whatever I got, I'm just telling you, this is how I answered. I just kept one format for CVS, CS, CNS, RS, and other systems or specific points for a specific drug. So if you have a format of telling for any particular drug, and if you stick on to that, no, you will be able to answer most of the questions. Okay.
Yes, yes.
Like this seems plausible, no? So we will not miss anything in the interim period if you are actually going and telling like this. You will not get a feeling of you told it very nicely, but then this is what they expect.
Yeah, got it.
Okay, so anyone else willing to try? I'll just ask few more drugs so that you need not feel like I haven't. I also felt I did not stick. I mean, I tried myself reciting all these in a particular way, but then in the exam, no, with that tension, I didn't even get in the same path which I wanted to tell. But then when I remembered for the second or third question, when I remembered this is the format I prepared for, I was able to at least answer 50% of what I prepared. So in the tension, we won't know, no, CVS effect, RS effect, it's okay. But then if you stick on to CVS, RS, CNS, or a particular format, you will be able to answer better.
Yeah.
Okay.
Yeah.
So anyone else willing to try? I mean, hello.
One else not.
Hello.
Yeah, hello, ma'am.
No, anyone else like Narendra sir and someone SD, ND?
I haven't prepared anything, madam.
Okay. Okay.
Sir, I didn't also prepare, sir. Please give it a try.
Last 4 days, I'm having 13, 14-hour days.
Oh, okay. No, it is understandable, but then
I can
the,
try, but I'm sure I'll not be doing. I will not be able to give good answers, but I can try.
No, it is not about the thing which I wanted to say.
I've read general pharmacology, specific I have not started yet.
Okay, so you will you be able to answer this question late? What are the mechanisms of drug interaction and what is their clinical significance? Will you be able to answer that? Because
let me try now.
Yeah. Just a second.
Drug interactions could be physico-chemical.
Yes.
Pharmacokinetic, pharmacodynamic. And maybe I can recall only these right now. Physicochemical, like protamine sulfate and heparin, because they are chemically antagonistic to each other. Protamine sulfate deactivates histamine. Then pharmacokinetic, when absorption and presence of one drug interferes with the absorption of the other or its action. The pharmacodynamic, when two drugs are having opposite physiological actions and cancel each other out.
Okay.
Can recall only this much, right?
Okay, it's okay. So, yeah, well, can you tell something about any drug combinations which are used clinically, which will have their adverse effects or like enzyme inhibition, enzyme activation like that?
I think while giving anti-tubercular treatment, rifampicin and isoniazid have opposite actions on hepatic enzymes. Rifampicin is an enzyme inducer and isoniazid is enzyme inhibitor.
Okay. Can anyone try about synergism, antagonism? Examples.
I can tell you the definition of these.
Okay. Okay. If anyone else is interested.
Synergistic action is when the two drugs have their action on the same site, but the action is not additive. Like 1 plus 1 is 2 only, not 1 plus 1 is 2.
Is 1 plus 1 is more than 2.
Yes.
No, so 1 plus 1 is 2 only. That is synergism. Additive is
that is additive.
No,
That is
additive is
action.
1 plus 1 is equal to 2 is additive.
2 and
And 1
synergism
plus
is
1
1 plus
is
1
more than 2.
Okay,
it is
okay.
synergism.
Yeah,
So synergism will
confused.
have differing mechanism of action, whereas additive will have a similar kind of mechanism of action.
Yes. Okay.
Okay. So additive list is MAC is additive. Like if you give sevoflurane plus isoflurane, then MAC is additive. If you give vecuronium and rocuronium together, they are additive because they act on the same type of action. So, but then if you actually combine two other drugs, say a hypotensive action with AC, both are hypotensives, I mean antihypertensives, nifedipine or AC inhibitors or clinidipine and AC inhibitors, AC inhibitors with beta blockers, like that. So they are synergistic.
They are synergistic. Yes.
Okay, and when you like combine two actions which cancel each other, then that is an antagonism. Like you use a beta agonist at the same time you use a beta antagonist, then they are actually antagonistic to each other. Okay, and for the pharma question, no, initially they may start with questions such this, like what are the mechanism of drug interaction? Tell something about agonism, antagonism, and can you tell something about this dose response curve, volume of distribution? These are there in Emma Plinkett, like one which if they ask, you can draw a graph and show them, and these are there in Emma Plinkett. And it's there in Smith and Pinnock as well. This pharmacokinetic interactions, dynamic interactions, and mechanism of drug action. All those things are the preliminary questions which you will be getting in the pharmac session. Or say something about local anesthetic, or say something about opioids and classify opioids like that. So the primary question will not be a drug as such. It will be a basic pharmacology question like, I mean, for my session, it was like this. Mechanism of drug action. My question was says what are the factors which affect the drug concentration in the blood after an IV administration of a drug. So you should say about what is the protein binding, what is the tissue blood flow, what is the volume of distribution. They will give you time to think. You can think and formulate an answer for you and then answer.
Madam, which book to follow?
Smith and Pinnock is fine. Smith and Pinnock is fine, and you can also hear to primary podcast. They have this podcast as well. So whenever you're free or stuck up in the OT, if you're not able to read, you can actually hear those podcasts.
Where can I find them, madam? I don't have the audios.
I'll just find out if I still have it.
Sir, it's on Telegram, sir. It's available on Telegram.
I really
would you be able to forward me?
Sir, actually I also don't have it. But yes, I will just search and I'll you are on Telegram, sir?
Yes, I am.
So I'll just search it and I'll forward it to you.
That would be great.
Thank you.
Yeah. So if you can hear those when you are actually stuck up in the OT or something, as if you hear a song, then it will be useful for you.
Yes,
that would be quite helpful. In the OT, reading is not that easy. Listening is
that's what I'm saying. So you can try that out whenever you're busy. So anyone opted for exams this year? Deepak sir, when are you giving your exam?
Ma'am, 29th of October.
October. Okay.
Is the date fixed? I think it was 26th.
Yes, sir. I got the mail. So in that day, to check my psych account, and on that they have mentioned my date as 29th of October.
Okay, I haven't got that mail yet.
No,
so maybe you can check your
SAC account. You have to check.
Yeah, maybe you can check your SAC because it's mentioned only in account only. They didn't provide it on the details in the mail.
Okay. Fine.
Okay.
I haven't checked. I'm also appearing in during those 3 days only.
Okay. So,
Okay.
Okay. So shall we end the session for today? If at all you want to have another pharmac viva or another proper anesthesia related viva, kindly message in the group so that I will have another session as well in the upcoming days. Like
Sure, ma'am. Sure, ma'am.
so this
Yeah,
session,
this time
no,
I'll
this
just
no, this time
prepare
no,
well.
yeah, that's what I'm saying.
Dr.
So
Deepak,
once,
you don't know. You don't need to worry. You will
yeah,
pass,
that,
pass with flying colors.
Sir, I
yeah.
don't know, sir. This is my third time and this is my last chance. I don't know what will happen.
No, you will get to, don't worry. And what I wanted to tell is that hereafter, if we have a viva session, it will be like as if I am the examiner and I will never interrupt you and I will just assess you and tell you what mistakes you've done at the end. So that's how we are supposed to improve ourselves, isn't it? So I should not interrupt you hereafter whenever we conduct a viva session. Since because today is the like only pharmac viva I planned for, and I'll add a session also in the later interim period, like if at all you want for the first session as well as for the third session as well, anesthesia session as well. So
And can we ask you for like why to help us in the viva of any topic or only pharmac in future?
No. What I'm asking is if you want to have a one-on-one viva session before going on for exam, if you want to have a proper viva session wherein I will be the examiner and you will be the examinee without even interrupting, I will just put the question like how my exam was conducted. I will try to conduct it to you.
Okay, and for
Okay.
any topic, no? I
For
like
any
complete,
topic,
like complete course.
complete, yes. If you want for
Okay, sure. In the near
anatomy,
future, I'll try to finish up my course and
yeah, that's
definitely will
what I'm
ask you
saying.
to.
So hereafter, if you put all you want to have, I'll try to fix some time because one session takes only 30 minutes. No, we can form a session of 30 minutes where we are in between the OTs, and this need not be live streamed, right? I'll talk with Gurunath sir also. We can have a one-on-one like you, me, Narendra sir, only three of us in a session or only you, me, and the five of us in a session, wherein we'll have, say, anatomy and that basic session. No? If there is a basic session, 20 minutes of only basic session, and that we get to over within 30 minutes.
Okay.
Okay, so we can plan something like that so that you will also be well prepared for exam. Okay.
Narendra sir, I found that those podcasts, but it's on my second phone. Can you just ping me on the Telegram? I'll just forward you the link because there are several videos. So
all right.
all the videos.
Yeah, would do that.
Thank you, sir.
Thank you so much. Sir. Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am.
Thank you.
Thank you, ma'am. Good night.
Thank you.